and it seems like it's going to be going ahead similar to this, what we've been experiencing for a little while still. A lot of things have changed, and we obviously were very sorry that we are not able to have our on-site, the physical meeting this year. We had to have it cancelled due to the COVID-19. It's still fantastic to be able to have so many colleagues online joining us today, and I would like to thank the ePAPSA Exco with all their support, and Professor Heinz Rode, who's also been still guiding us, and we're going to be hearing the Heinz Rode lecture shortly as well, and I'm also delighted to see that he's online, joined us today. We thought we should have a meeting on this platform. It's something new for most of us. We have been having our perhaps smaller meetings online, but we haven't really experienced a meeting where the presenters will be presenting their research studies, and even will be able to have some poster presentations going to be presented later today and tomorrow. There are a lot of things have changed over the last year, and we will be able to share, and we'll be able to comment on these things as the presenters present their research studies. And we obviously encourage colleagues to comment and ask questions. It's always nice to have some ground rules, so we'll keep the language to English as we've been doing with other congresses that we've had. And we would like colleagues to turn off their microphones and mute their microphones if they are not the speaker for the session, for the presentation. It just helps to minimize the echo, and also refrain from writing or creating any annotations on the screen. It's again wonderful to see so many of you joining us online. It's really great privilege for us to be able to host this meeting. We will be starting with the first talk, and it's my great pleasure to introduce our speaker to you today, this afternoon. Professor Larry Hedley will be giving the Heinz Rode lecture today. Professor Hedley graduated from medical school in 1971 in Scotland, and then he spent quite a few years in the variety of countries, which span across to Jamaica and then to South Africa, and sometime in Papua New Guinea as well as a lecturer. And then he returned back to Durban in 1983 as the lecturer, and then subsequently became the head of the Department of Pediatric Surgery in Durban in 1990. We all know that he has a tremendous amount of interest in pediatric surgical oncology, but he's also got interest in attending to the diseases in developing countries, and also surgical education. He's been the past president of the South African Association of Pediatric Surgeons, as well as the International Pediatric Surgical Oncology Group. He has examined in many colleges, not just for the South African College of Pediatric Surgeons, but other colleges in the continent as well. He's also been the moderator for our college for quite a long time. He's published a lot of papers, over 150 papers, and contributed to chapters that are more than 20. So it's really a great privilege to have Professor Larry Hedley today with us, who's going to be delivering the Heinz Rode lecture, which is titled Pediatric Surgery in Africa, Are Western Solutions Appropriate or Applicable? Prof. Hedley, we're looking forward to your talk.
Can you hear me, Al?
It's loud and clear, Prof.
Okay, well, Al, thank you very much for that very generous introduction. You made what I thought was quite an ordinary career sound almost exciting. Thank you very much indeed. I would like to join you in thanking the Executive Committee of PAPSA for inviting me to join this meeting. It really is fantastic to see my name being added to the list of illustrious pediatric surgeons who have delivered this lecture in the past. I'm truly flattered. It would be remiss of me to start this lecture without thanking my colleague, Sam Sheikh, who, despite running a busy paediatric surgical practice, has made time to coach me, a Zoom conference novice, in the fine art of the technology of this program. If everything runs smoothly, then Sam Sheikh should get the credit. But if it's an absolute dog show, then you can blame me. I would also like to thank the audience for joining online. If you hadn't done, I'd have been sitting here in my study talking to myself, which would have been highly unproductive. So thank you very much for joining in. Now, as time is moving on, we had better get the lecture started.
So let us turn our attention to paediatric surgery in Africa. I think it's common cause that the paediatric surgery in high-income countries is more developed than it is in the low-income countries of sub-Saharan Africa. And what we've got to consider is whether the solutions that evolved in high-income countries can be imported directly to Africa, and whether they are appropriate or applicable in our environment. This lecture, of course, is given in honour of Professor Hirschprung, who was one of the founding fathers of PAPSA and an important driving force in the evolution and maturation of the project. It is an honour for me to be associated with a man who, throughout his career, has been a fierce advocate for the children of Africa, as well as for, in particular, the paediatric surgical care of these children. Back in 1991, at a meeting in Nairobi, a group of paediatric surgeons from around the continent got together to discuss the potential of forming a Pan-African Association of Paediatric Surgeons. As you can see in the background there's a very young Professor Rueda, and on the right, a very young Professor Hadley, trying very hard to hide behind Dr. Forhese and failing miserably. I don't think I would get much argument if I was to say that Africa has been enthralled of the colonial states of Europe for centuries, and that very rarely, if ever, has this relationship been to the advantage of Africa. Indeed, the exploitation of Africa's resources, be they human resources, mineral resources, or any other sort of resources, is largely responsible for the failure of development on the African continent. Some would say that Africa is still popularly regarded as the dark continent. But I think we can all agree that, well, certainly those of us that live here, that Africa is far from an homogeneous geopolitical entity. And it is highly unlikely that we're going to find a one-size-fits-all solution to any of the problems of Africa, least of all the problems facing paediatric surgery in Africa. But we all share an interest in the welfare of the children of the continent. And of course, we want the children to be alive. We want to save as many as we can. But we want them to grow up with a quality of life that is acceptable to them and to the communities in which they live. Current distribution of wealth around the world is quite deliberate. These are the results of policies imposed upon low-income countries by the rich countries in the Northern Hemisphere that are quite happy with the current situation and see no reason to change it. In fact, were there a serious desire by governments in rich countries to help with the problems of Africa, the first thing they would do is get rid of this iniquitous wealth distribution policy, which ensures that Africa cannot develop once it is in place. And this is reflected in this cartogram of the gross domestic product of various countries. And you can see the countries of Europe, North America, China, and Japan all have very large GDPs. In Africa, it is represented by a string with a slightly bulbous end, a sort of scrotal appendage that is South Africa. And this impacts healthcare in a number of ways. Firstly, consider if Ethiopia were to treble the percentage of its GDP that it spends on healthcare to rival that of, say, the Netherlands, they would still only have $51 per annum to spend on health, as opposed to the 6,000 that the Netherlands has available. And of course, this in turn translates into the number of physicians available to the community. If we look at the cartogram of physicians per population, they're almost exactly the same as the GDP cartogram. Europe, North America, China, Japan, with large numbers of physicians per population. But it's worth noting that 50% of the world's physicians serve less than 20% of the world's population. So a perfectly legitimate question in Africa is there a doctor anywhere? It is, however, very important for us as paediatric surgeons to recognise that we are not the only specialty affected by a shortage of personnel. All other specialties are limited in staffing, as are the generalists as well. Where are all the surgeons? Well, I couldn't get data for the whole of Africa, but if you look at this limited selection of countries, Uganda is the best off, with 3/4 of a surgeon per 100,000 people, as opposed to America's 38. And in terms of paediatric surgeons, we have 3 in Uganda versus 1,150 in the USA. The density of paediatric surgeons within a population is an interesting thing to study. In Turkey, we see that there is a paediatric surgeon for every 25,000 people. Now, 25,000, that's not even a half-decent football crowd, but there's a paediatric surgeon. And on this diagram, the higher your tower, the less well off you are in terms of paediatric surgical density. And you can see that Sweden is severely disadvantaged with a paediatric surgeon for every 95,000 people. When you add South Africa into the situation, Sweden suddenly looks quite good. In South Africa, there's a paediatric surgeon for just about every 1.8 million people. And most of the people in South Africa are, in fact, children. Whereas in European countries, the population is aging, and the proportion of children in the population is small. When we add in Niger, of course, even South Africa looks good. In Niger, there is a paediatric surgeon for every 18 million people. In Francophone Africa, the situation is pretty similar. We have a couple of outliers in Côte d'Ivoire and Gabon, where they are flush with paediatric surgeons, but for the most part, there's a paediatric surgeon available for somewhere between every 2 and 5 million people. But probably a more important metric is the number of live births per paediatric surgeon per year in each country. When you look at this graph, I'd like you to just think of a pathology that has an incidence of perhaps 1 in every 3,000 or 3,500 live births. And for me, esophageal atresia is a perfectly reasonable model. If you were a paediatric surgeon working in Austria, where they see only 500 live births per paediatric surgeon, you'd have to wait 6 or 7 years before you could reasonably expect to encounter a esophageal atresia. Even in the UK, the average paediatric surgeon is only going to see approximately 2 patients with esophageal atresia per year. Now, these numbers are insufficient to maintain surgical skills and certainly insufficient to maintain the institutional skills of the entire care team. And it is this sort of metric that makes the centralisation of services for children so attractive to these countries. So, for example, in the UK, biliary atresia can only be treated in perhaps 3 centres in Leeds, Birmingham and London. In the Netherlands, all oncology surgery for children is performed in a single hospital in the middle of the country in Utrecht. And there are similar situations throughout the developed world. In South Africa, you can see that every paediatric surgeon will see on average 10 patients with esophageal atresia per year. And this is quite sufficient to maintain personal surgical skills and to maintain the institutional skills that are required by these patients. Now, an important paper out of Nigeria, almost 10 years ago now, showed that in these 7 countries, there was a deficit of 775 paediatric surgeons. And since this paper was published, of course, things have got considerably worse because the population growth has been much faster than our ability to churn out paediatric surgeons. And if we were to extend this survey to the other countries of sub-Saharan Africa, we would find that the deficit was very much larger. Now, in response to these deficits, it seems obvious that we should be training more paediatric surgeons. But I'm not entirely sure that that is a rational response. Paediatric surgery is a team event. And a paediatric surgeon on his own is a very sorry beast because he can't actually do very much. Without the team around him, the paediatric surgeon is virtually helpless. So what we're talking about in improving access to paediatric surgery is that we've got to uplift the entire health service of a given country. That's not going to happen anytime soon. I also take issue with our colleagues in Nigeria who say that the best way that paediatric surgeons in America and Europe can help us is by forming exchange programs between trainees. Now, I have no doubt that in the United States and Europe, the rich countries, they would love to exchange trainees with Africa because they could, because they have insufficient patient loads themselves, they can send the trainees across to Africa to get some cutting practice and some management experience. But sending an African trainee to Europe or the USA often misfires because they become trained on pathologies that we don't see in sub-Saharan Africa, and they become dependent upon technologies that are not available in sub-Saharan Africa. And when they return, they become disillusioned, frustrated, and very rapidly immigrate. And of course, all this is going to get worse because over the next few years, we've got another 1.6 billion babies coming our way. That's 1.6 million 1,000 times over. So there are a lot of babies coming, and this far outstrips our ability to train paediatric surgeons. This, of course, is a direct result of the fertility of Africa, where on average, women have between 5 and 6 children each. Now, population increases threatens all resources, not just municipal swimming pools. It will overwhelm health services and it will overwhelm paediatric surgical services in particular. also, of course, overwhelm the beachfront at Durban. This is an annual migration which takes place each year on January the 1st, and one looks forward to an increase in population with some trepidation. The Ponte di Legno Declaration, which was drawn up with acute lymphoblastic leukemia in mind, says the treatment for curable and potentially curable disease is a fundamental right of children everywhere, and that includes children in Africa. So as I look at the current situation, I think there are not enough paediatric surgeons in Africa, and most importantly, there never will be. There is no way that we can produce paediatric surgeons at a rate that is commensurate with the population increase. Yet we are still going to have millions of children requiring surgical care. So we have to task shift. And we can either task shift to general surgeons or to people who are non-doctors. When I suggest this, I'm often told that, but our health administrators won't allow people who are not medically trained to operate on anybody, let alone children. And I say, well, if that is the case, if the rules don't allow it, change the rules. Because failure to see this as a disaster waiting to happen is simply sticking our heads in the foam. This attitude is entirely commensurate with the founding philosophies of our specialty. Pediatric surgeons have never intended to create a monopoly, and this concept that every child in Africa who needs an operation should have his operation performed by a pediatric surgeon is simply a non-starter. Our role as pediatric surgeons is to set the standard for the surgical care of children and to teach those who are going to provide it and conduct research. And there's nothing new about task shifting. It's been going on in Malawi for years. It's been going on in pediatric surgery. It's been going on in anesthesia. It's been going on in oncology. And it's been going on in many countries across our region. But it's interesting, as you get more aware of this literature, one sees the names of high-income countries frequently appearing as they grasp the economic advantages of having people who are not doctors performing some of the tasks that are traditionally performed by formally qualified medical practitioners. I think our teaching should start at undergraduate level. It was as an undergraduate that I was first attracted to paediatric surgery as a specialty. And in at least one Indian province, it is now mandatory to teach paediatric surgery to medical students. And by law, this must be taught by practicing paediatric surgeons. It's interesting that at our own university in South Africa, paediatric surgery has been removed from the undergraduate curriculum because the medical administration felt that the medical students would benefit more from further experience in orthopedic surgery. I'm sure this is a grossly retrogressive step. If we can look at the situation in Malawi, which is a country that has reported its experience with probably greater frequency than most, we can see that by 2007, 87% of the obstetric procedures and some surgical procedures were performed by clinical officers. But to me, the most important number on this slide is the 38. They performed these procedures in 38 hospitals. That means that these patients were having their care provided at their local hospital, and patients were not having to be transported to the major centres in Blantyre and Lilongwe for treatment. And the results that have been achieved by these non-medically trained surgeons are identical to the results obtained by formally trained medical officers. The alternative is to leave our patients in the care of Isangoma, the traditional healer. Now, traditional healers have a very important role to play in the management of disease in Africa, but their role is very rarely in the management of surgical diseases. This is a child who presented with a nephroblastoma, and you can see that by the time she came to hospital, the scarification marks of the sangoma had healed. And of course, for many pathologies, such a delay could indeed be disastrous. Or we can leave our children in the care of Inyanga, who will treat diseases with the ground down bones of a warthog, or perhaps the fetal remains of one or other variety of antelope. There's a downside to traditional medicine, of course, that this largely seems to stem from the insatiable desire of Oriental gentlemen for larger and more frequent erections. Now, the next few slides all pertain to Wilms tumour, which many of you will know has long been an interest of mine. But you can ignore that title at the top there. You can put in your own whatever pathology you fancy, because the principles involved, the principles that this illustrates, are the same across a range of pathologies. But with Wilms tumour, we learn from our colleagues in a high-income country, in this case the USA, that the overall survival is 90 to 95%. So why is this still a problem for us? Well, the answer is, of course, that these first world authors, like first world authors in many conditions, simply sweep results from poor countries, but the poor results from poor countries, under the carpet, because we represent the inconvenient truth. There's a well-recognized and very great survival gap between children with childhood cancer in low-income countries and high-income countries. If one was to work out the global survival rate of Wilms tumour around the world, you'd probably find it somewhere between 35 and 40%. And that's because most childhood cancer arises in children in low-income countries, 80% of it. And a low survival amongst these children has a significant impact on the global survival rate. And childhood cancer survival, we know, is directly related to the per capita gross national income, again reflecting the fact that the exploitation of Africa is still having an impact on the mortality of our children. It also, of course, the gross national product, gross national income, of course, determines the number of physicians available and the amount that the government has to spend on healthcare. Now, when these figures are broken down by age and sex, as your speaker this afternoon has been, you'll see that the top right-hand corner with the high expenditure, high survival figures are all the usual suspects, the rich countries of Europe and North America. And down on the bottom left-hand corner, the low expenditure, low survival, this is where we find the names we recognize: Senegal, Tanzania, Bangladesh. Now, these countries are not down in the bottom left-hand corner because that's where they want to be. They're down there because they have a limited gross national income, they have limited health, limited money to spend on health, and they therefore have low survival figures for childhood cancer. Which is something of a tragedy, because starting from a low base, to get the survival up to 85% would not cost a great deal of money. In fact, it's rather more organizational than expenditure that improves the survival at this level. The massive expense of paediatric oncology care comes when you're trying to push your survival from 85% up towards 100%. This is when you need the expensive therapies, the expensive supportive care, the high-tech genetic studies, and the high-tech investigations. But I would be delighted if we could get survival for childhood cancer in Africa up to 85%. That would indeed be. But governments in Africa are faced with the funding black hole of communicable diseases. And I've often said that if I was a health minister of a sub-Saharan African country, that I would spend my budget on malaria prevention, on malarial treatment, the scourge of diarrheal diseases, and the number of children that die of these. I would measles vaccines, treatment of HIV/AIDS. These are the things that would consume my budget, and the amount of money I had available for developing paediatric surgical care would not be large. However, dotted around our continent, there are institutions where the skills of the staff and the facilities available rival the best in the world. This is in Corte Tuli, where I work, and I know that there are similar centres of excellence dotted around the country. But I think we would all be more familiar with this sort of ward in an African hospital. And you can see that it's crowded, people sleeping on the floor. It's a mixed ward with orthopaedic surgeons down at the end and what appear to be gynecology patients up at this end. And this is more typical of the continent. And this is the sort of operating theatre in which most people in Africa have their surgery performed. It often interests me to think that if one of the ladies listening this evening were to have a caesarean section performed in Malawi, she'd probably be the only doctor in the room. The anaesthetist would be a clinical officer, not medically trained. The surgeon would be a clinical officer with no medical degree. The paediatrician would be a clinical officer. Yet the results are identical to the results achieved by a team, each of whom had an MBCHB. Now, I don't want you to read all the quotations on this slide. Just reading one or two will give you the general gist. These are all extracts from a single report of an oversight visit by a group of parliamentarians to a hospital in South Africa. And I show this to you merely to demonstrate that hospital infrastructure deficiencies are a problem for all of us. In West Africa, in hospitals doing paediatric surgery, 10% have got no permanent power supply, half of them have got no running water, 10% still using oxygen concentrators, and 1 in 5 doesn't have an X-ray department. And this lady is standing in the room thinking, what on earth would I do with a Da Vinci robot? Which brings me to this machine. I don't know whether you recognize it, but this is a high-income country, high-tech bottle opener. And you put your bottle on the stand at the bottom, the yellow arms swing out to grasp the neck of the bottle. The gantry from above descends. The bottle is gently rotated to make sure the crimping on the bottle cap aligns correctly. Then the machine slowly tilts and removes the bottle top. Now, this is a fabulous machine. It's great fun to watch it at work. But it doesn't work if there's no electricity. And of course, if something goes wrong with it, it can't be fixed. This is the African equivalent. Importantly, it's important to note that it is just as effective at taking off a bottle cap as the high-tech machine to the left. But it doesn't need electricity. And if it breaks, let's make another one. Yet for some reason, we seem obsessed with getting the high-tech solution when there is a simple African alternative that is freely available. Let me just illustrate what I'm trying to say by looking briefly at Hirschprung's disease. In the West, if you haven't passed meconium by the time you're 24 hours and 1 minute old, you will get a neonatal suction biopsy. This will go off to the pathologist, and you will get the result tomorrow. The patient would then have some washouts and be prepared for a primary laparoscopy-assisted pull-through with a stable anastomosis. Problem solved. In Africa, we get leg diagnosis Many babies are born at home or in small clinics. And by the time the baby comes to the attention of a diagnostician who can make the diagnosis of Hirschprung's disease, the patient usually already has abdominal distension, he's got basal chest infection because his diaphragm hasn't been descending, and the child is already ill. There's no urgent pathology available. You can take your mucosal biopsy if you so desire. You can fix it in formalin at your hospital, but then it has to be transported to another hospital some hours away for pathological assessment. And if it doesn't get lost, you can get your result in 10 to 14 days. We have limited laparoscopic skills. I don't mean by this that the laparoscopic skills of an individual surgeon are in any way limited. We've got some of the finest laparoscopic surgeons on the planet working in Africa, but they tend to work in large hospitals in large cities, and that's not where the patients are. The patients are in small hospitals in rural areas. So the patients have limited access to the laparoscopic skills and facilities that are available. And of course, we don't have any staples. So we must cut our suit according to our cloth. I think we should be teaching make a colostomy. And we shouldn't apologise for doing this. We're not in competition with laparoscopic surgeons in high-income countries. We're just living in a different world. But colostomies are safe. Well, by safe, I mean an end colostomy. I'm not talking about that abomination of the surgeon's art, which is the transverse loop colostomy. Colostomies are safe. They can be performed by general surgeons, and they allow you to make a planned referral and have an elective pull-through when the patient is well enough to tolerate it. And of course, in neonates, you do not require stomach care. All you've got to do is pull the nappy up an inch. Another example would be jejunal atresia. In the West, you get often an antenatal diagnosis, but certainly the diagnosis is not long in coming in the postnatal period. Once you've got over the excitement of being born, around about 36 hours, you'll have your operation. And at the same time, they will put in a central line and provide you with total parenteral nutrition. In Africa, we've got late diagnosis. Often for exactly the same reasons that Hirschprung's disease is diagnosed late. The same pertains to jejunal atresia. The babies are starved. They are all small for gestational age, so they've been starved in utero, and then they have several days of postnatal starvation and continuous vomiting, so there's also dehydration and electrolyte imbalance. We don't have TPN available. So we've got to change our teaching. Right? We've got to teach people to put in feeding jejunostomies or to do Bishop-Koop type anastomoses. Because by the time we see them, patients with jejunal atresia are starved and septic. TPN is not possible, and we've either got to find another way to feed the baby, or we all stand around the bed and watch the baby starve to death. Now, I was doing this 40 years ago in Papua New Guinea. We would aspirate the nasogastric tube, get a mixture of binogastric acid, mix it with EBM in a bottle, and then refeed it down a feeding tube through the distal limb of the Bishop-Koop. Yes, it's time-consuming. Yes, it is messy. But yes, it works. We also have available a significant body of highly intelligent, bright, enthusiastic, young graduates who would be keen to do research into things that might affect the welfare of children of the continent. They're not that much interested in doing yet another retrospective review of wound infections in Little Pudwick General Hospital. But if you show them a research project might have a significant impact on the way we conduct paediatric surgery, they'd be very keen to become involved. So the future, I think we should continue to train paediatric surgeons and conduct research. I think we should maintain robust undergraduate programs because the undergraduates are our future. I think we should insist that general surgeons have a paediatric experience. I don't think a surgeon should be allowed to practice in Africa unless he has spent a considerable time in a paediatric surgical unit. And no matter where on the continent a general surgeon is going to work, the demographics of Africa mean that a significant proportion of his patients are going to be children. We should train African surgeons in Africa, that I've no doubt, so that we get appropriately trained paediatric surgeons available. And we should avoid hyper-specialization and hyper-localization. Hyper-localization is a particular threat because paediatric surgeons are all based in big cities, in big hospitals, and the patients are in small hospitals in rural areas. We should support our African structures, and we should also support African journals. I think it's very important that we publish the results of our work in journals that are read by our peers. And I think we've all had the experience of having our papers rejected by European and American journals simply because our results do not match those that can be achieved in a high-income country. And last but not least, we must look at the clinical officer cadre and see how it can be used to bolster the staffing in anesthesia and in paediatric surgery. So that's all, folks. I'd like to thank you very much for spending time with me, and I look forward to seeing you at the next meeting live.
Thank you very much, Professor Headley, for the wonderful lecture. Really appreciate it, and it's come through okay to my side. And I think some colleagues might have had some minor audio problems, but the rest could hear and view the presentation very nicely. And thank you very much. There are a lot of thought-provoking and comments have been made and suggestions have been made, and there's a lot of lessons that were in your presentation. Really appreciate that. It's really been wonderful. We will not be taking any questions for this presentation, and again our appreciation to give this year's Heinz Rode lecture. Thank you very much. I'm going to be handing it over to the chairpersons of the next session now, and that's Professors Shihatas and Professor Afwe-Hesse from Ghana, and they'll be introducing the speakers for the next part of this session. Thank you very much.
Thank you so much, Alp. I'm sure that all agree that we have just listened to a wonderful talk by Professor Headley, talking about the difficulties and challenges in Africa, and a roadmap for the future for solving these problems the African way and not the Western way. Actually, it is for the dedicated work of African pediatric surgeons, like the people behind the ePAPSA. There is remarkable efforts to improve and to go forwards with the progress of pediatric surgery in Africa. And I must say that with the work and collaboration with experts overseas from different countries who has dedicated work in Africa that help to improve. And I think the collaboration with international organization will be very helpful, because the current, for example, the current president of the UFAPS is from Africa, 2023. And the coming president, 23-26, again will be from Africa, who will be Alp Numanoglu. So don't miss this opportunity to collaborate with the International World Federation for a lot of chances of collaboration and teaching and workshops and mutual exchange. Thank you again, Professor Hadley, for a wonderful presentation. And it's my great pleasure to co-chair this first session, Global Surgery and Education, with Professor Afua Hesse. And I think he's going to introduce the first paper. Professor Afua.
Thank you very much. Much appreciated, and nice to see everybody, even though we're not meeting face to face. It's nice to be able to meet all of you, even in this session. First speaker that we have is Rosemary Mugwe, who is going to speak to us about the kids' operating room. Rosemary, you have the floor and you have 10 minutes.
Okay, Rosemary.
Is Rosemary with us?
Yes, she's been unmuted now. You can start sharing your presentation. Here we go.
Thank you so much. My name is Rosemary Mugwe, the Kids Operating Room Director for Africa. I'll be presenting on behalf of David Cunningham, Garrett Wood, Kids OR, and all our partners. Our presentation is titled Improving Access to Children, Surgery in Africa, the Kids Operating Room Initiative. My presentation is going to include what is on your screen. I will start by telling you who we are. So who is Kids Operating Room? We are a UK charity based in Scotland with an Africa office in Nairobi. The founders of Kids Operating Room are Gareth and Nicola Wood. Our mission is to support local doctors through provision of training and infrastructure to ensure that they can use their skills to care for their nation's children. Now, what informed the establishment of Kids OR is the love that the founders and ourselves have for children. We were seeking equity of access for children to access surgery. Now, why did we do this? Because sadly, it is estimated that 1.7 billion children lack access to surgery. It's also estimated that 85% of children in developing countries need surgery of some sort before their 15th birthday. It's further estimated that a third of all the childhood deaths results from a surgical condition. More children between age 5 and 14 die every day of surgically treatable injuries than from malaria, HIV, and TB. Infrastructure remains a limiting factor in delivering children's surgical care in low middle-income countries. And the population of children we know is huge. For example, in sub-Saharan Africa, 50% of the population is of the pediatric age. This is a huge population to ignore. Now, to measure the magnitude of the problem on the ground and to come up, we came up with a pilot project to see how we could assist. And by that, we made a call for applications to hospitals who are interested in improving their pediatric surgical capacity and who were willing to dedicate an operating room or operating rooms to children specifically. Our aim was to provide them with surgical equipment for children's surgery. We targeted 2 locations, that's Africa and Latin America. Initially, we got 18 applications. Over 60% of those that applied were designated training sites. The average number of operations per year was 1,668, and the waiting time for elective surgery was up to 22 months. None of the sites had specialized pediatric anesthesia provider. Most of the sites also reported using surgical equipment not specifically designed or trained for pediatric patients. Now, our initial projects that we did installations in were in Uganda, that's Naguru and Mbarara, and in Tanzania, Muhimbili National Hospital. Now, I'll take you through a case study of the Muhimbili National Hospital that's post-installation. What you can see on your screen is a typical kids or theater that's post-installation. That's how beautiful and all the equipment we put in. And when we did that to Muhimbili National Hospital, as you can see, there's an arrow that's indicating the introduction of the kids OR theater in 2017, where they had had operations, 522 operations. And 1 year after that, you can see the numbers doubled. So this is clear proof of impact. Cases doubled, deaths and disabilities prevented. Now, we wanted to do more as Kids OR. We wanted to come up with a comprehensive approach, not only provide equipment, but we needed to do more for these children because the need was dire. The results of that need is that we partnered with COSEXA, we partnered with WORKS, we partnered with ePAPSA and WFSA to design a 10-year strategy for Africa. What are we going to do to ensure that we have comprehensive pediatric capacity in this region? And that roadmap that we developed with the partners mentioned outlined the following. We will create 120 centers of excellence for children's surgery. We believe in giving the right tools to the skilled people. We will provide ongoing supportive training to designated biomedical engineers who will maintain those equipments that we have installed. We'll provide education grants for general pediatric surgeons and pediatric anesthesia training, with priority given to countries that have none, because in this region we have countries that do not have a single pediatric surgeon or a specialized pediatric anesthesia provider. We also said in collaboration with the colleges, we are going to create an e-learning platform for ped anesthesia and ped surgery that will support the WORKS and COSEXA qualifications. Note that this creation of an e-learning platform that's ongoing is not intended to lead to its own qualification, but to support the already training programs that these colleges are delivering. We'll also continue to research and support innovation, enhance training, provide evidence on the impact of investing in children's surgery, and of course, advocacy. We have to make a case for children's surgery and economics of surgery. What are the achievements we've had so far? 25 since 2017, we've had 25 operating rooms installed with plans for 34 more by end of 2021. We've already given 10 pediatric surgery trainee scholarships with the aim of doing 10 more by 2021. And like I said earlier, we're giving priority to countries without single pediatric surgeon or minimal and pediatric anesthesia providers. We have also gone ahead to advance. That strategy we developed with the partners is now an action plan. We have done a situation analysis in each and every country in sub-Saharan Africa. We have identified the 120 sites where we will do installations for dedicated operating rooms for children. We have identified countries and the number of training scholarships we're going to provide. And this exercise was done in each country in consultations with the surgeons, the partner hospitals, and the ministries of health. Why ministries of health? Because once training is done, we want them to deploy. And why Ministry of Health, again, is so key is because we want them to provide the consumables in the operating rooms that we install. Again, we have increased partnerships with like-minded charities, and this has really amplified our impact. So what am I saying in conclusion? Our initiative as Kids OR takes up a horizontal intervention, running away from the piecemeal vertical intervention. We are doing installation of equipment. We are training. We are doing advocacy. We are doing research to inform our work and progress. There is improved surgical access through infrastructure investment. We know that impact on children's surgery starts from the operating room. It then cascades throughout the families and the rest of the society. This initiative supports countries to attain universal health coverage in line with the resolution from the World Health Assembly, and of course, across many SDG as outlined there. This initiative has also been developed to meet the needs of each country. Like I said, each country made its own plan after a situation analysis we did together. Now, Kids OR cannot do this alone. Strong partnership with pediatric associations, regional and international champions, ministries of health, and other partners will be so key to build sustainable programs. We will continue to give you progress of our evaluation for growth and development. Thank you, and I'm ready to take any questions.
Thank you very much, Rosemary. You really stuck to time. That was a fantastic effort you made.
Thank you.
We will proceed, and I guess questions will come at the end of the session. People can note them in the chat, and we will moderate all of them. So I'll hand you over to my co-chair to introduce the next talk.
Thank you so much. The next talk is about met and unmet needs of pediatric surgical access in Uganda, results from a countrywide prospective clinical database by Peter Kaima. 10 minutes.
Okay, thank you so much. My name is Peter Kaima. I'm a general surgeon from Uganda, northern part of Uganda, practicing in Lacho Hospital. I'm happy and thank you for having me for this presentation. We have no disclosures if you look at the best presenter highlighted that 5 billion people worldwide have access to affordable surgical care. And this 5 billion, actually 1.7 is children. And so, and this 5 billion mostly is found in low and middle income countries. If you look at Uganda, surgical capacity, pediatric surgical capacity is really limited. We have only 6 pediatric surgeons. We have no pediatric surgeon in the rural regional referral hospitals. And our population in Uganda, 20 million, we have a population of 46 million Ugandans, and only 20. You can imagine we have a very big pediatric population, 20 million in Uganda. And if you look at in 2015, a nationwide children's surgery stakeholders meeting was held. This was mainly to address the pediatric surgical capacity in Uganda. And the plan in this meeting was to increase collaboration between the rural regional referral hospitals and the tertiary centers in Uganda. And these ones mostly the ones from the city, Mulago and Barara. And in this collaboration, mostly what was discussed is mainly training fellows in pediatric surgery, supporting general surgeons in rural regional referral hospitals, and through outreach like surgical camps and And at the same time, a clinical prospective database was developed. And this database was initially developed in Mulago, but later on it was implemented in the 4 regions in Uganda, as we shall see in the map that covers all the health facilities in Uganda. And these facilities, as you can see, if you can look at the map, the stars which are written in red, we have Mbarara in the western region, Mulago in the central, and then we have Soroti and Gulu, which is enlarged from the database, includes from January to 2016 to January 2018, 2 years. And the purpose of this study was to mainly estimate the distribution of pediatric surgical cases managed in regional referral hospitals in Uganda, and also to estimate the surgical coverage of these pediatric surgical conditions in Uganda. And if you look at the hospitals, we shall start with Mulago. Here it covers almost more than half of the country, because it's a national referral hospital. We get referrals from different hospitals or different regions in Uganda. We have Mbarara here. Mbarara supply catchment area is mostly in Mbarara, Western Uganda. And then Lacho, which covers mostly the northern part of Uganda, as like that. And then Soroti covers the small part of eastern part of Uganda. If you look at from our data, we have about 1,300 patients captured in this data in the 4 hospitals. Specifically, we have about 700 patients which we reviewed from Mulago. Mulago is written in blue, and then this is Mbarara, and this is Soroti, and then this is Lacho. You can see mostly we have congenital anomalies in Mulago and Mbarara, but significantly what I wanted to say as previously that it's only Mulago and Mbarara where we have pediatric surgeons. Other centers like Soroti and Lacho, it's only the general surgeons who handle the pediatric surgical conditions. Significantly, if we see here, infections in hospitals which have general surgeons managing the pediatric cases, we have mostly infections and trauma and burns, which are more compared to other, but it shares all the cases that we have in the country. And if you look at the age distribution across all the hospitals, we have the pediatric cases actually which are seen in all the regions in Uganda. The average age is about 3 years, and mostly we have very young patients, infants mostly seen in most of the countries, and very few toddlers and other ages. So we mainly see the average of about 3 years of age. If you look at the postoperative mortality in Mulago and Mbarara, which have pediatric surgeons, certified pediatric surgeons, board certified, we have mostly mortality increasing more, but this is because these are bigger center, National Referral Hospital in Mulago, which has most of the patients going there are very sick and very young, so we have mortality. But as far as we have these congenital anomalies contributing a lot to the mortality, and then also the general surgical pathology. Infection and trauma a little bit contributing less. Now, this is just briefly of the surgical cases that are seen. The database involves all patients admitted with pediatric surgical conditions. And if you saw in the map, we have these regions covered in all regions in the country. And if you look at the DALYs averted from the pediatric surgical delivery in these hospitals, in 1 year, we have about 27,500 DALYs averted per year. in the management of these cases in Uganda in all the 4 centers. And if you look at most of the DALYs as affected to anorectal malformations, Hirschprung's disease, intersusception, inguinal hernias repairs on varicocele, operative abdominal trauma, and others. And if you multiply these DALYs with a value of statistical life expectancy, we found out that estimated economic benefit that is achieved is about $22.7 million US per year in the management of cases with pediatric surgery. Where does this one take us in the projected pediatric surgical volume? As we know that surgical capacities, surgical volume is one of the biggest indicators. And if you look at our patients we have 6 pediatric surgeons for 20 million children. That's about only less than 2% of the projected.
1 minute.
The projected, only one, yes. And if you look at 1,400 patients which are seen in Uganda, in the middle income country, this one only, if you look at the high income countries, only this one goes only 1%. So we have a very big job to do in the coverage of increasing surgical capacity. We have only 1% to the global target. Thank you so much. Actually, this was my last presentation. And
Thank
these
you so
are
much.
a group of people and pediatrics in Lacho. Thank you so much.
Thank you so much, Peter. This analysis is very important for decision making. I congratulate you and thank you for this effort. And we move on to the next presentation.
Thank you very much.
Thank you.
The next presentation is also from Uganda, and it is by Martin Situma, and he's going to speak to the implementation of a pediatric emergency surgical care course for rural frontline providers in Uganda. And you have 10 minutes, please.
Yes, thank you very much. I'm Martin Situma from Uganda. I'm presenting this as a design and implementation of a pilot pediatric emergency surgical care course for rural providers. We did this as a bridge between the few pediatric surgeons and the big population we have to try and bridge the gap as we try and train more. I think this has been presented well. We all know the need, the big need we have of surgery, especially for children and especially in sub-Saharan Africa. So I'll not go through that slide again. And as my predecessor said, we are only 6 pediatric surgeons at the moment. So the deficit is still big. And as the answer to this deficit, we tried to design a course which could bridge a gap to attend to the clinical needs for the rural providers, especially for the emergencies. This is a 3-day curriculum. It's taught largely by the Uganda faculty and targets non-specialist rural providers. On day 1, we deal with abdominal emergencies and incarcerated hernias. We do anesthesia and then neonatal bowel obstruction. On day 2, we look at the anorectal malformation and Hirschprung disease, anti-abdominal defects, and neurological emergencies. On day 3, we do some orthopedics and then trauma and burns. This course has been conducted 3 times at separate sites since February 2018. And was interrupted because of COVID this year. The methods we do a baseline needs assessment survey, which is at all attendees. The participants in the 2nd and 3rd courses took a pre and post course knowledge-based tests. We've had 45 participants. The 18 were in our capital city, which is Kampala. And then we had another one in far west of the country, which is Mbara, and then another one in the northern part of the country, which is Gulu. 63% of these had completed pediatric surgery rotation during their training. The mean time since the attendees completed the training was about 3 to 4 years. And these are the qualifications. The majority of these were medical officers, about 30% were surgeons, and then 17% were others, including nurses. And these were the monthly pediatric surgery volume they attend to in their hospitals. So the majority of patients they saw were 0 to 10. When you look at the infant surgery, the majority saw about almost 20 patients. And when we look at the anesthesia provision for these centers, so the majority is provided by an anesthetic officer. Only 17% had anesthesiologists, 11% had both of them, and then 2% were using other people, maybe nurses or the medical officers themselves. The most common procedures performed, by far the hernias took the largest percentage, and then a couple of other pediatric surgical emergencies, interception, burns, laparotomies, leukodopexy, and a couple of other things. When we assess their confidence in managing this condition, the highest ranked was inguinal hernias, hernia repairs, then interception, and the least ranked was, of course, cleft lip repair, and the more complex pediatric surgical cases, anoplasties, intestinal atresia, and a couple of other things. When you ask about barriers to safe surgery in children, the biggest barrier was lack of consumables and infrastructure. So we were happy about kids OR's presentation. The next was anesthesia. Of course, and then of course the patients presenting with very advanced disease, which is still a big challenge. There was lack of appropriate trained staff, support from senior personnel, and then many other community-related issues. When you ask about interventions needed, most attendees thought that hands-on surgical training was the most important, and then more frequent CMEs, improved anesthesia delivery, and up to improved transport to the hospital, that is concerning the patients. When you look at the scores before and after the course for the 2 pre and post tests, we saw a significant improvement in the scores in the post test, such that most of the students scored almost above 70 compared to the pre-test. So the limitation in this study, of course, was a pilot study. There are no long-term follow-ups to evaluate if the training changes practice patterns. So our next step was to do a mixed method, implementing studies needed to evaluate the long-term and the impact of this training. So in conclusion, non-specialist clinicians are essential to pediatric surgical workforce in low and medium income countries. We think that short targeted training courses can increase the provider knowledge about the management of surgical emergencies. And then delivery of the course by local providers minimizes the cost and facilitates sustainability. The course has spurred locally driven surgical outreach initiatives, increased referrals to specialized pediatric surgical care, and of course, decreased mortality and morbidity. Thank you very much.
Thank you very much indeed. That was indeed a very interesting presentation on a course that certainly needs to be evaluated. I've seen a number of questions about the course. So in the question and answer brief, we will take some of these comments briefly, and maybe you can address them. Thank you very much, Martin. I'll hand over for the next presentation.
Thank you. Actually, I see a very good awareness of the size of the problem in Africa by very good scientific analysis and trials to improve the situation with the available resources. So again, I'm very happy and congratulate all the speakers for these efforts. Now, the next speaker will speak about the growing pediatric surgical training in Africa through Pan-African e-learning approach. This is a part I like very much because I'll give you a comment after you speak. This will be given by Eric of Lynn. Eric, you have 10 minutes.
Thank you very much. So I'm Eric O'Flynn from the Royal College of Surgeons in Ireland, Institute of Global Surgery, and I'd like to thank the organizers for the invitation to talk to you all this afternoon. I'm going to discuss something that was briefly mentioned by Rosemary Mugwe, a Pan-African e-learning pediatric surgical training platform.
Martin, can you stop sharing from your side so that Eric can start sharing?
Okay, can you see my slides?
Yes, go ahead.
Great, okay. So first of all, to acknowledge that in collegiate training programs in sub-Saharan Africa, the workplace is the primary site of acquisition of skills, behaviors, and attitudes. It is the primary training center, training site. But we believe that there's an important role for online training as an adjunct to in-service training. This project is bringing together 4 institutions: Kids OR, who you've already heard from, COSEXA, WACS, and the Royal College of Surgeons in Ireland, to build a Pan-African pediatric surgical training e-learning platform. The primary aim is to support surgical trainees in the WACS and COSEXA program, and support them through the entire course of their training program. But secondary objectives are also to support surgical trainers, indeed to provide a resource for qualified pediatric surgeons, and to help to grow the pediatric surgical community and to enhance communication between the pediatric surgical community. We started off by blueprinting the course material against the WACS and COSEXA curricula to make sure that it satisfies the training needs of both colleges. We have a group of subject matter experts, many of whom are in the meeting today, who are involved in creating and curating the content for this course. Much of the content pre-exists in many other sources, but really one of the challenges for this project is bringing it all together in a structured way that ties in with the curricula of the 2 colleges. As Rosemary mentioned before, this is not a standalone qualification, but rather a support for the 2 colleges' training programs. And it's expected to enhance the experience of the trainees and indeed improve their prospects of success in exams. It is structured with 27 monthly modules, 9 monthly modules per year. The months in which there are exams in the COSEXA and WACS calendar do not have e-learning modules. All the rest of the months do. Each month has a weekly module, and they run in the same sequence every month. The first week of the month, there is a module discussing a topic related to general professional competence, such as communications, non-technical skills, patient safety. The second week of the month is a case-based discussion. The third week looking at a specific pediatric surgical topic. And the fourth week is again a discussion, this time focusing on surgical procedures. So broadly speaking, there are 2 different types of module. The first and the third week are very much self-directed, while the second and the fourth week are very much discussion-based. We'll have a look now at what that looks like in practice. So self-directed modules are learner-driven. They're taken either on a computer, a laptop, or indeed on a tablet or phone in the learner's own time, on the evenings, weekends, whenever they find they have time, and they can progress through the course, drop it, come back to it as suits their own schedule. The courses present a large amount of information, as we said, both newly created and curated information, and they're also interactive. They give the trainee a chance to test their own knowledge at the start, at the end of each course, and indeed all the way throughout, and also to reflect on some of the questions posed throughout the course. They also point the learner to resources for further study, be they journal articles, videos, and other resources. And you can see throughout this presentation on the right-hand side, we have some screenshots of early modules. These are self-directed modules. Discussion modules are entirely different. They're moderated discussions on specific topics. We have case discussions based on real scenarios. We also have discussions around particular surgical procedures. The learning in this case, we feel it's as much from the trainees' own peers or the trainees as it is from the moderators. And again, these modules also have pre and post discussion material to prepare the trainee for the discussion and for them to gain more around the topic. And some of the questions from discussion modules are posted on the right there. As we said, 4 institutions are involved in this. We have to extend our thanks to Kids OR for funding and for driving this. WACS and COSEXA are in the main providing the content for the course, and RCSI in the main part are providing the technical support in bringing this together. We also have to thank a number of trainees that are involved in testing and giving feedback on this. We believe that this electronic learning platform is a very useful tool that's going to support pediatric surgical training across the region. And frankly, we're delighted to be able to work on a Pan-African basis and to be able to present this work in a Pan-African forum. The platform is going to officially launch in May of next year. We look forward to working with many of you indeed on this call throughout the creation of this platform. And thank you very much for your attention.
Thank you so much, Eric. Actually, this is a wonderful initiative and a very good way to overcome difficulties in training in low and middle income countries is through electronic media and e-learning. It will overcome the barrier. It will transmit high quality information and skills, and it can be a discussion forum for some of the real cases. I would like to highlight the point that I am moderating a Facebook page called the Pediatric Surgeons Lounge, where there are more than 3,500 pediatric surgeons from around the world who are discussing everyday cases. So I would like to merge or have some collaboration between your platform, and I invite you all to visit and join the Pediatric Surgeons Lounge on the Facebook. Again, congratulations, a very good initiative and could be a solution to many of our problems in Africa. Now we move on, and I handle the presentation of the last talk to my co-chair, Professor Afua.
Thank you so much. Indeed, there's a lot to be done, and COVID has taught us how to do a lot of e-learning, a lot more e-learning. So this is great as a way of sharing our knowledge. The final presentation for this session talks about surgical non-physician clinicians Sub-Saharan Africa, identifying deficiencies, I guess, in the current training. Hello,
Hey, yes, I'm here.
Okay, hi.
Hi.
You have the floor.
Nice to meet you. Thank you so much. My name is Yumna Sharif. I am a general surgery resident at the Baylor College of Medicine, and I'm very excited to present today about our topic, surgical non-physician clinicians in sub-Saharan Africa, and a review of the literature identifying the deficiencies. Our senior physician who is on this research is Dr. Bip Nandi from Baylor College of Medicine and from KCH. This research was related both to KCH and Baylor College of Medicine efforts. I have no disclosures. So to start off, the delivery of surgical interventions in austere settings has the potential to significantly reduce the worldwide disease burden and to improve disability-adjusted life years and expand surgical access. The World Health Organization has prioritized surgical capacity building, task sharing, and education of local providers in an attempt to emphasize this or accomplish this goal. Non-physician clinicians, especially in sub-Saharan Africa, are key players in this process of surgical capacity building. We'll take a little bit of time to discuss that. Non-physician clinicians cannot be underappreciated and are defined as a healthcare provider who's not trained as a physician, but who can provide diagnostic and clinical functions such as delivering anesthesia, managing chronic illnesses, and performing certain surgical procedures. Non-physician clinicians provide necessary skilled care with decreased duration and cost of training than physicians normally require. Additionally, NPC training can focus on practical interventions, increase the healthcare workforce in a specific setting, and facilitate access to healthcare in settings with low physician densities. Specifically, sub-Saharan Africa has a documented history of NPCs and their instrumental role in the provision of care during emergency situations, pandemics, general medical care, and surgical care. Therefore, we thought it was essential to review the literature produced on NPCs in order to define their contributions to surgical capacity and identify any research gaps that were noted. In order to do this, we conducted a literature review that adhered to the PRISMA guidelines. We identified the specific key terms that we were interested in, created preliminary exclusion criteria and inclusion criteria. We then conducted a literature search of Medline Ovid with the mesh headings and the equivalent keywords and phrases that we had come up with. We translated this method to Medline Ovid, from Medline Ovid, to M-based Scopus and the Cochrane Review. The titles and abstracts of each of these publications were reviewed separately by two independent blind screened reviewers, and then the matchup, the articles reviewed completely in order to create a final compiled list. So this is kind of a flow chart of what we were looking at. So globally, our search terms were contingent on population, location, associated terms, and topics of concerns. So for our particular case, the population was defined as non-physician clinicians and the equivalent terms, i.e. mid-level nurse practitioner, physician assistant, medical officer. The location was limited to sub-Saharan Africa, and we used the World Bank definition of the countries located in sub-Saharan Africa and ran this search with each country entailed in it. The associated terms in which NPCs are often associated with are capacity building, health implementation, scale up, and task shifting. We arrived at these terms for a preliminary scoping review. And the topics of concern were specifically staff development, professional development, and in-service training. With these key terms, we found 415 articles, and then we ran them through our exclusion and inclusion criteria while we were choosing which abstracts and titles were most relevant. Our exclusion criteria specifically looked at any articles that were produced outside of sub-Saharan Africa, any articles that focused on non-physician clinicians that were medical. We limited the definition of surgical to those surgeries that were involved in the 44 essential surgeries as defined by the World Bank. So this spanned the field of general surgery, obstetrics and gynecology, orthopedic surgery, urology, burn surgery, plastic surgery, OMFS, and ENT. And then anything that didn't address our search terms directly, we excluded. In terms of our inclusion criteria, it was limited to sub-Saharan Africa. The articles had to be in English, as the primary researchers spoke English. and occurred within the past year as global surgery gained popularity within these last 30 years. We were able to find 28 unique articles that focused on 5 domains of interest that we developed through a thematic analysis of these articles. So in terms of the thematic analysis, we found, again, 5 main domains. The first was candidate selection, i.e. which individuals became NPCs and what was required for their training. And that includes both duration, length of time, and skill sets covered. Additionally, a significant portion of the articles actually focused on an assessment of NPC knowledge and assessment of NPC results, meaning their clinical outcomes. So oftentimes the articles would compare complication rates, for example, of hernia repairs or cesarean sections. And then there was an issue of assessment of knowledge, i.e. if an individual came into the emergency department, would there be a capacity to appropriately resuscitate and then appropriately triage that individual? And then finally, there was some literature on the assessment of barriers that NPCs experience as they try to develop their careers. So kind of in the literature, we noticed that there is a pretty significant emphasis on NPC clinical training and clinical competence. However, there isn't really a fully developed set of literature available on the professional development of NPCs that includes the perspective of non-physician clinicians. And this can be concerning because if NPCs are unable to have meaningful careers, their impact on the surgical burden of disease will be limited. Therefore, future studies must address deficiency in NPC professional development, NPC mentorship, NPC agency, and NPC perspective. And this type of research in turn has the potential to enhance the performance of NPCs in clinical settings, increase NPC buy-in, and prevent NPC attrition, providing for an overall increased retention of workforce and increased access to safe, timely surgical care. Thank you.
Thank you very much. Indeed, that's a very important component since we're talking a lot about mobilization of non-physician clinicians in pediatric surgery in particular. Thank you very much for that.
Thank you.
I think this would bring to an end our session. My co-presenter, can you access the questions, some of the questions that have been raised, since we have a few minutes more that we can cover? So I understand all the presentations are going to be uploaded onto the PAPSA website. So we should be able to download them. There was a comment about the launching of the e-training program, and Elebute says this is indigenous and ingenious. I guess they wanted to say, I look forward to its launch. And Amarlis said, great talk, Eric. I'm looking forward to using the platform. Dr. Situma's presentation, Dr. Shabal said the course should have a practical session on the common surgeries a general surgeon or medical officer should be able to offer. For example, herniotomies, orchidopexies, divided sigmoid or transverse colostomy. There was a question to Martin. Who funds the training program? Is it your Ministry of Health? And does your training include surgical skills training? And then Naomi asked whether it could be made available for others to be used. For instance, could it be made available for the Global Initiative for Children's Surgery website? Rosemary, you were asked, or For countries in the continent that might be considered middle income with an already established clinical practice and infrastructure, do such centers still qualify for assistance for the kids OR? And is there any possible assistance with skills training, grants or fellowships, and improvements to established infrastructure? From Uganda, there was a comment from Bauchi that I like this analysis from Uganda. And Egypt said the North African countries have the capacity to provide effective training and formation to pediatric surgeons and anesthetists. And you can refer your patients to their hospitals. In that regard, the issue is always cost, because when you refer patients, the limitation for them going to the referral centers, at least in our experience, is costs. So if there's some comments that the presenters would like to make, they can have a minute or so each to make any comments that they would wish. Rosemary, do you have a comment?
We can start one by one, and each one can be given 1 minute to comment. We start with Rosemary. Would you like to have a quick comment?
This is Rosemary. Yes, I have a comment, a response to the question about the middle income countries. What we do when we get into a country, we do a situation analysis. What exists, what does not exist. Now, if we get into a middle income country, we will do the same and evaluate with the surgeons, the associations, the hospitals, the ministries of health. We're going to evaluate the situation and see what kind of intervention we can make that is most impactful. If they have the specialists and lack the tools, we will provide the tools. If they have the tools and do not have the specialists, then we will provide the specialists. So it's something we do in consultation. And yes, to answer the question, we are also in middle income countries like Kenya is. Thank you.
Thank you so much. We move on to Peter Kayema, 1 minute, quick comment. Unmute yourself.
A comment on the analysis in Uganda. It shows that pediatric surgeons are few, so we need to empower and train and support the general surgeons in the regional referral hospitals to provide work to supplement on the pediatric surgeons who are very few, and they're only in the cities. So in the rural areas, we need to find a way to empower and support the general surgeons. That's all I have to say. Thank you.
Excellent. Thank you so much. Martin, you have something to comment? There is a lot of questions about your courses. Unmute yourself, please.
Yes, thank you very much. First, I completely agree with the session from the feedback we got from the participants, but we're limited by time and resources, as that was the initial course. But we hope that in the subsequent ones shall have a practical session. About the funding has been gotten through collaborators. We have been budgeting about $2,000 per course. Per course per region. But this one may increase, available for gigs. I think that should be easy as soon as we get it, because this was the initial one, and we are trying to improve it and, not miss out some of the emergencies, improve the practical sessions, And so when we do all this, we hope that we can share this with GIGS. Actually, some of the collaborators are members of GIGS, so I'm sure we can do that quite easily.
Excellent. Thank you so much. Now we move on to Eric O'Flynn and the e-learning platform. Quick comment.
Thank you. Thank you for the kind comments. I would just say in terms of cooperation with other platforms and other resources that already exist, as you've pointed out, Prof. Shahata, we'd be very open to that and indeed keen on such cooperation. And I suppose in the spirit of cooperation also, we will be reaching out to fellows of WACS and COSEXA over the coming months and indeed years for assistance in content creation and moderating these discussions. And we hope for your kind cooperation.
Excellent. Excellent initiative, actually. Congratulations, Eric. Thank you so much. Now we move on to the last but not least speaker, Yomna. Quick comment. Unmute yourself.
Okay, yes. Again, thank you so much for this opportunity. I'm very happy to be here. Just to kind of continue the conversation that was discussed, it's the limitation in terms of training for pediatric surgeons that are available allows an avenue for non-physician clinicians to kind of step in and assist with this entire process. So it would be interesting, I think, in the future to see how specifically we can set up a professional development program for non-physician clinicians in pediatric surgery. Thank you.
Thank you so much. Before I leave my co-chair to conclude, I would like to say two things. One, we have just finished exactly in time, so I congratulate all speakers. And we have listened to very high quality talks. Actually, I personally enjoyed. I think it's very enlightening and it shows the way ahead and the roadmap to the future. Thank you so much. Wonderful session and to all speakers. And I leave my co-chair to conclude.
Thank you very much. I'd like to also thank all of you for your rapt attention. Thank the presenters on our continent. And this forum affords us the opportunity to get acquainted with what is happening all around. And then we can put in our inputs and see how best we can all contribute to improving pediatric surgery for the children of Africa. Thank you all very much for your attention.
Thank you very much to the chairs of this last session and the presenters. It's really been a fantastic session. I really enjoyed it all the way down in south here at the tip of the Cape of Good Hope. We are just a housekeeping announcement. So we're going to be moving the poster viewing session scheduled for today to tomorrow. We've got very short time for that, so we really would like to give them adequate time. So that's going to be combined with tomorrow's poster viewing session for a slightly longer viewing opportunity. And I will be asking Professor Essam El Halabi from Egypt to introduce our next speaker. Thank you.
Thank you, Al. Thank you, everybody. Just would like to share the slides, please. Omar, can I allow to share the first, just this slide?
Yes, you go on. You can share them. Yes.
Yes. Okay. Okay. Let me start just to read it. This is I would like to thank all of you. This is the first session on the. It was a really fantastic session, and the one before the plenary one, Hans Rodal lecture, was very stimulating, and it's actually grasped the attention of everybody who attended this meeting up to now. The next presentation will come from Dr. Abdurrahman Samad Sheikh. Dr. Sheikh was graduated from Nepal and from Durban, South Africa, and he is currently the head of the Division of Pediatric Surgery at the Stellenbosch University in Cape Town. He has been a council member since 2014 in the College of Pediatric Surgeons of South Africa, and he's a senator in the College of Medicine of South Africa. Dr. Sheikh is the current president of the College of Pediatric Surgeons of South Africa since 2017. He has a long special interest in administration, telemedicine, robotic, fetal and neonatal surgery. He has several scholarships from UK, from the United States, and from Belgium and France. Dr. Sheikh was gonna talk about COVID-19 and competency, the new normal in examination. Dr. Sheikh, please, we are all looking forward to hearing you.
Thank you very much for your kind introduction. I just need to correct that I am no longer the head of pediatric surgery at Stellenbosch University because I wanted to move back to Durban. But overall, good evening to all, and thank you, Al, Essam, and the organizing committee of this meeting for giving me the opportunity to share some of our experiences and to present sorry, I'm just trying to share the screen, and to share our experiences. I do so on behalf of the Council of our College of Pediatric Surgeons, who have worked tirelessly on actually trying to make our exit examination in pediatric surgery a valid, reliable, and defendable one over the last few years. The road to specialization in South Africa has only recently been set, and it has progressed since 2010, when the Health Professionals Councils of South Africa, which is our registration and regulatory body in the country, legislated that a single exit examination administered by the Colleges of Medicine of South Africa would be required to register as a specialist. This strategy was introduced to centralize and to standardize the examinations for all specialist trainees. And around the same time, the pioneers of pediatric surgery in the country motivated and managed to change the status of pediatric surgery from a subspecialty within general surgery to a fully fledged specialty in its own right. The road follows a path where one needs to enter a rather competitive training program in one of the 8 medical schools that we have in the country. Once they are in the program, they have to complete their primary and intermediate examinations and comply with the regulations which are regularly updated on the college website. Having done this, they may then sit the exit examinations of the College of Pediatric Surgeons. This has traditionally been a high-stakes, focused examination that has combined written and clinical assessment. Part of the requirement of the specialization in pediatric surgery is the completion of the research component, which is in the form of an MEd administered by the university that the trainee is registered at. The period of time allocated for this training is a maximum of 5 years within a numbered or recognized training post by the health, after which time the trainee has to vacate that post. Once this is completed, the final step is registration with the Health Professionals Council of South Africa, which is a licensing body that also serves the purposes of regulating the profession. This step is mandatory if you wish to practice as a specialist pediatric surgeon in South Africa, and is based on completion of the steps that we have mentioned before. So this is the sort of route to specialization that is still being followed until the onset of the COVID-19 pandemic and the public health response that was required. This response was required to minimize the catastrophic spread of the disease and required an immediate change in the traditional approach to both medical education and assessment. The last few talks that we heard this evening have actually looked at all the different ways that we could change the two methods of medical education. For us, it provided a catalyst to transform our assessment methods into a valid and reliable tool. A particularly challenging aspect of education during the pandemic was the substantial restriction of clinical learning experience for our trainees. This was as a result of a limited supply of personal protective equipment, restricted testing for COVID-19. There was concern of the highly infectious nature of the virus, and this led to institutions implementing protocols that severely limited patient contact. Additionally, patients stayed away from our hospitals, limiting the surgical caseload and therefore limiting the learning experience that our registrars were exposed to. So for trainees around the world, the culmination of their years of sacrifice is associated usually with a high-stakes examination as their exit examination. These examinations are used to certify and at times select employment opportunities as they are integrated into the workforce. This is exactly what would happen in our setting. However, this minuscule coronavirus wreaking havoc and limiting social contact rendered us impotent in terms of performing the typical examinations that we would conduct. And we needed to rapidly readdress the options that we have. There may have been a number of alternative approaches, but there appear to be three main options that we could have followed. And the following of these options could be categorized by taking from the standard operating procedures of our anesthetic colleagues when they assess our patients preoperatively. The options that they usually offer to us are to avoid, cancel, or delay the procedure that is planned. So faced with this dilemma, we sought to find the right approach and addressed several key issues before deciding on how to proceed with our response to COVID-19 and final exit examinations of our colleges. If we avoided the examinations, then we would have to utilize existing continuous performance assessments to promote trainees. We would replace this with the teacher or expert provided assessment, but our problem would then have been as to how we would be able to ensure accurate and fair assessment using a retrospectively applied opinion as compared to a prospective one. If we canceled our examinations and had no examinations until the pandemic was under control, then we would need policies in place to make decisions regarding the training time, the job allocation, and the appointment of new trainees, preserving and ensuring that we preserve transparency and fairness during this process. Delaying the examination using the best models we had available to estimate the time that we could apply this examination would require a move to an online format. So after discussions and many meetings, a delay was opted to and was in fact in any case mandated by the lockdown regulations that were implemented in our country. REM knew long before we did how to express the overwhelming perception and sentiments of many people in the world with regards to the COVID-19 pandemic and its influence in our daily lives. Many will remember the COVID-19 pandemic as a source of disruption, but our college used this opportunity and viewed this as a catalyst to implement our idea of training and assessment that had already been a few years in the making. We had recognized that doctors must embrace the competencies that are required of our profession and that our assessment methods must be defensible, reliable, and valid. To this end, we looked at competency versus certification and realized that certification is simply an acknowledgement that a trainee has completed the requirements of a course and demonstrated knowledge of the subjects concerned. This is very different from competency, and if we look at Miller's criteria for competency, it shows that we require enduring competencies both in professionalism, service to our patients, and personal accountability. And this requires an ongoing continuous assessment and a change in the way our exit examinations were being conducted. The pace of this change has already been steady in our college, but slow, and this was the ideal opportunity to rapidly catapult our assessments into competency-based type assessments. I do not think that any discussion on competency and pediatric surgery or competency assessment can pass without any comment on the recent sad state of affairs in healthcare in South Africa, with the deliberate victimization of colleagues and the subsequent vigilantism. And this is placed on us an onus as the bodies conducting the exit examination to assess competence as effectively as we can. The trial by media on the competence of professionals needs to be aggressively opposed, and our thoughts, support, and prayers are with our colleagues who have been inflicted with this disaster. The Fellowship of the College of Pediatric Surgeons exit examination used a composite test format to assess the candidate's knowledge of clinical skills. Although this format, which has been presented, has been in place since inception, it has been steadily refined till the entire examination has been fairly standardized and structured as far as possible within the constraints of the conduct of the exam. The written paper now covers a wide variety of topics, and by limiting it to just short answer questions, a memo is easily applied, allowing objective marking of the candidate's answer. The spot test and the viva, or the oral viva, have for a long time been assessed and standardized in terms of the type of questions that would be asked. The clinical cases, though, have always been a problem. They have not been standardized. Questioning is done away from the patient and so does not directly assess any clinical interaction. And this is particularly important in the long case. The component of clinical interaction and assessment of this was left purely to the short cases where the candidate was observed during their clinical examination. This format has served us well over the last 3 years, but it does have some limitations and addresses only a few of the components of the pyramid of competency that I described earlier. However, it is still considered a certification examination as it in effect tests knowledge at one point in time, and according to experts is not completely defensible, but should withstand most questioning. Clearly, one can see that the new normal in many ways is a maturation of our examinations that were already in place. The yellow highlights the changes that we have made in these examinations, and you can see that for each one of the components of the examinations, they have just been formalized and standards have been applied. Although the changes appear relatively minor, they were a major undertaking in terms of meeting pedagogic standards in which most of us have no training. The appointment of an educationalist, who was also a specialist physician by our college, has facilitated this development and provided us with huge insight into the modern methods of teaching and assessment. It should be noted, though, that in each of the oral components that we have in this examination, we have built in a small percentage which allows the examiner the discretion if he wishes to explore the candidate in a deeper fashion. An important aspect for us in terms of developing this new normal allowed us to recognize or identify the pitfalls with the old. And these pitfalls included that the written paper was unstructured, open-ended, the patient himself was non-standardized, and at this particular instance, the contradictions of COVID that applied to these particular clinical interactions would be a problem. I'll briefly mention the trapdoor area in a little while, as this was also an area of concern for the people who were involved in the pedagogic side of our examination preparation. The important thing about the old examination was that it's very labor intensive, it's time intensive, and it requires significant commitment from the individuals involved. The financial implications are further compounded by the immense impact that COVID has on the economy, and it is very unlikely that the ongoing increase in examination input costs can be met by the candidates, as this is already quite a high figure. We used this opportunity, though, to involve our entire pediatric surgery fraternity. We wanted to get all the consultants involved, from the very junior, recently qualified ones, to the most senior colleagues. In this way, we thought that we would ensure the fresh knowledge of the new consultants could be utilized, and we would also ensure continuity and training as the specialists matured and then entered the fold of the examiners themselves. For the development of the SBA questionnaires, this was quite difficult, it was long. We considered the option of purchasing a database, but the cost was prohibitive. But the bigger concern was that we were worried about whether this would be applicable or the content would be applicable to our practice. So what we had was a workshop where more than 90% of the active pediatric surgeons in the country were invited and attended. They were trained in the methodology of setting SBA type of questions, and the afternoon was then spent developing, vetting, and correcting these questions, and followed by standard setting, and this venture produced around 200 questions. Following on this, each candidate was then allocated 2 to 5 sections in which they needed to produce 5 to 20 questions each. And the commitment from our colleagues in this process was remarkable, and we have now established a workable database within a short period of time. A similar approach was utilized for the other aspects of the examination. Just to briefly mention, the trapdoor component actually refers to the situation where there is one particular aspect of the examination which will determine whether the candidate will pass or fail. So in our examination, there was one clinical component, which if the candidate failed, he would be considered to have failed the entire exam. According to the educationalist, this was not fair, as the rest of the examination would then be considered null and void. And the way to correct this was quite easy in terms of applying simply a weighting of the different components based on what we thought would be the most important aspect of each area. Once we had developed this new system of setting the examination, we were forced to implement this. But then we realized slowly that COVID itself is a multi-system disease, and it would affect all the systems in place for our examinations. The influence was not only limited to the dangers of physical distancing during the conduct of the examination, but had other far-reaching ramifications. Some of these included the global mobility of our students. It is a significant issue in many developed countries where postgraduate education is a major contributor to the economy of those countries. But to a smaller extent, it also plays a role in South Africa, where we train a fair number of international doctors who seek to pursue their specialty training. And this raised some unique problems as encountered by one of our candidates who wished to take our examination in the coming weeks. Due to travel restrictions of the country he had returned to, he is now going to be confined to the hold of an aircraft, since only cargo aircraft leaves his country to fly to South Africa. Additionally, other problems such as training time, where you are restricted to just 5 years. Although this is an important aspect to consider, we should be cognizant of the fact that in South Africa, the training has in fact been reduced by 6 months or 17% due to the effects of the pandemic and the lockdown. Fellowship programs for our candidates and for others outside of the country are also important, and as these enhance our skills, it enhances the skills of trainees, and it improves the service delivery when they return to our country, but these become inhibited due to the limited mobility that has been influenced by COVID. So overall, there are a number of different aspects that that have influenced our examinations and our ability to deliver them. For the future, we have continued with establishing what we have already discussed, but COVID having taught us to live in the present, but at the same time planning for the future and learning from the past, shows us that the days of traditional educational methods have ended. The buzzwords are now of blended learning, and now the norm will continue to be developed and refined, as our colleagues have shown us in the previous few talks that have been given. We will have to identify those methods employing the wide array of social and communications media that are available, and identify from those which will work best for our profession. What is, however, definite is that we will have to move towards a workplace-based assessment using a thorough, structured, and continuous assessment approach. In order to ensure that this is fair, we have embarked, one of our candidates and trainees has embarked on a project to review the past 10 years of portfolios that are required by our candidates, and using these to summarize and establish what the criteria would be in a realistic fashion for candidates in the future. So as we enter the COVID-19 recovery phase, hopefully this is what will be happening, it will be critical to reflect on the role of our educational systems, and particularly vocational education, because that is effectively what medicine is. The global health crisis, the lockdown that has followed, has brought to the fore the professions that have been taken for granted, and it renews our awareness of their value to society. But if anything, this pandemic has exposed our vulnerability to the crisis and revealed how precarious and interdependent the economies we have built can be. Ensuring that all young people have the opportunity to succeed and develop the knowledge, skills, attitudes, and values that will allow them to contribute to society is the heart of the global agenda of our college and I think of future society. So thank you once again, ending with the words of REM in terms of what we are likely to foresee in the future. Thank you.
Esam, you just need to unmute yourself.
Oh, thank you, Professor Shea. This is a very much interested talk. And actually, as you have shown to us, it might be COVID which push us to think twice regarding the current curriculum, the current teaching methods, the current assessment methods, the previous teaching and assessment methods, and how to improve them. The rate of change becomes very quick due to the requirements of this pandemic area and pandemic disease, which we are suffering from. Few questions actually. The first, mind, how many of these changes will stand after clearance of this pandemic, which we hoping to be cleared as soon as possible? And second, do we need to have a unified curriculum and unified ways of assessment all over the country, the continent of Africa? Because there is a different teaching and different training protocols and different curricula and also different assessment methods in different parts of this continent. Is it time to try to unify our effort to having some unified curriculum and assessment from Kosika and the West College of Africa and also in the North Africa and South Africa? What is your feedback?
Thank you for those comments, Prof. In terms of the first question, what will be maintained and what will be implemented from now on? Our intention is to change our examination completely to the system that I outlined. It will be sort of single best answer type of questions for the written paper. It will be clinical patient scenarios, which will be paper-based, and a structured oral examination from now on. Just also to comment on that, I see one of the questions in the chat was regarding whether we have found a way to really replace clinical examination and how to assess this in physical science. That is where our workplace-based assessment comes in. We do have a protocol that we are working on and will soon be implemented, which will require all our registrars to be assessed on a regular basis in a variety of different categories. They are currently already assessed, and every 6 months, their head of department gives them a report which looks at and identifies things like clinical examinations. It looks at patient interaction. It looks at punctuality, professionalism, and that will be formalized and implemented. In terms of standardized training for the rest of the continent, I think over the past couple of years, we have had to be slightly selfish in terms of how we have looked at our examinations. And the main reason for that has been because there have been many areas in our examination and the conduct of our education of our trainees that we were not happy with. We needed to refine this. We wanted to make sure that we would have a system which would be defensible and which would be up to the standards of any examination internationally or would stand up to scrutiny. And we've had several examiners from other colleges throughout the world, including the United States, the UK, Australia, who have attended our examinations to provide us with feedback. But saying this, I think we have now reached the stage where we are more than willing to share our experiences and learn from our colleagues in the other societies, and to somehow carry this forward and ultimately have just a single African type of examination rather than multiple different standards to apply. So our college will certainly, and I'm sure I speak for all our members of our council when we say that I think it is time to move ahead with your suggestion.
Okay. There is a question from George Youngson. Are you confident that workplace-based assessment are sufficiently objective and rigorous?
The reason we have not implemented it completely as yet is because it is in the process of being validated, and the application or the employment of an educationalist in our college has provided us with a fair degree of objective measures that we can use to assess this. Given the way our actual workplace assessment is conducted, there are opinions from a number of different people rather than a single person, and that's provided at each of the institutions. The actual registrars themselves also have considerable interaction with the different centers in varying different ways, and utilizing some of the guidelines that are recommended for assessing the validity and reliability of workplace-based assessment. So far, the ones that we have in place do seem to meet some of these criteria. But once this is proven sufficient by the people who know, these are the teachers and the educationalists, then we will implement that. I don't think it will be ideal, but I think it certainly will be a lot better than what we have in place at the moment.
Yeah, sure. Thank you. Just one more question. In the new way of this assessment, how sure you see that it will assess the not just the knowledge and the skills, but the attitude? Because the attitude in large depends on contact, and observing the contact of the physician, of the students with his patients and his the other healthcare provider. So do you think will we meet a problem of assessing the attitude in such new scenarios?
Yes, certainly. I think this professionalism that you are talking about is a very important aspect. It is something we have considered over a period of time, and it's probably the most important part of the portfolio that we pay attention to. And this portfolio includes a 6-monthly assessment by the head of department and the consultant who is training that particular registrar. The limited exposure we had, which is why I specifically mentioned that for the long case, we did not observe the interaction. We only observed the interaction during the short cases. I think that's a very limited time period to make that sort of a judgment, and relying on an ongoing or an input from the people who interact with the trainee over a long period of time will be far more useful and far more helpful. But the professionalism aspect is probably as important as the knowledge-based part, as you have mentioned.
Thank you very much. If there is no other question, we can go to the conclude this session to prepare for the coming session. Thank you very much, Professor Chair. Thank you for all the participants. Thanks for the interactive participation from all of you for this session, also the previous session. Thank you.
Thank you very much, Sam, and also would like to thank all the speakers, the Heinz Roder lecturer, Professor Larry Hadley, and the presenters of the oral presentations, and Professor Sheikh. Also would like to thank the chairs of the sessions for their contributions, and of course, all the participants. We still have more than 100 people joined us online. It's getting late here, certainly, I'm sure in your own areas as well. And thanks for being with us. Before we start the AGM, just would like to highlight that tomorrow we're starting at the same time. It's 4 p.m. Central African time. And we have a very well organized program, I must say. It's all around COVID-19 tomorrow. So it's going to be an interesting time, interesting presentations to listen to tomorrow as well. We will also have the posters presented tomorrow. Next, we have on the program is the general meeting. And the general meeting, of course, it's open to all our members. They are encouraged to attend. If you're not a member, it's not a closed meeting, so you're still welcome to attend. If you're not a PAPSA member, you're still welcome to attend our general meeting. I will ask if Professor Ademuyiwa can also switch the microphone on. Hi, Soji, thank you very much. We're going to share the agenda with you. And from my side, I would like to welcome you all to our general meeting. We have a number of issues to discuss on the agenda. It is not an election year this